All right, everybody. Thanks again for joining us this evening. It looks like we have enough to consider it a captive audience, and more might jump in, but I'm really happy to be able to partner with the Plastic Surgery Research Council today to bring this program to you. My name is Blaine Hamilton. I'm the Director of Medical Affairs and Professional Education at Sientra. And we really, in this time of COVID, one of the primary reasons to do this program is to support the council. Usually used to going to the meetings with them and seeing so much great research. So they gave us an opportunity to be able to share some of the innovation and experience of this expert panel with the new AlloX2, the expander with also a drain function. So I'm really excited to be able to introduce our panel today. I'm just going to hand it over to Dr. Justin Sachs out of WashU to be able to do that. So again, thank you all for being here. Please, keep on mute as much as you can, but during the discussion, please feel free to put your camera on and join the discussion. With that, Dr. Sachs, all yours.
Thanks so much, Blaine, and really appreciate Sientra's support of the Plastic Surgery Research Council in supporting this symposium. And we have a really nice panel tonight with Dr. Arash Amameni and Dr. Suhail Kanchwala, which I'll introduce after. But tonight's title of the symposia is Managing Outcomes in Breast Reconstruction and Expert Experience with the AlloX2. These are my disclosures. So pre-pectoral breast reconstruction really has undergone an evolution. Back in the 80s, when we first started doing two-stage breast reconstruction with tissue expander and implant, it was originally in the pre-pectoral space, and then this evolved into submuscular due to some problems with infection and implant exposure. Then, continuing on to partial submuscular with marionette sutures, and then eventually bringing in some dermal matrices and meshes, where you have the sort of dual plane, and then recently evolution to a little bit more of the pre-pectoral plus or minus dermal matrices and fat grafting. So it's really what we've seen in the past 30 years is really a sort of an evolution in two-stage breast reconstruction and just in the placement of tissue expanders on the chest wall, either above or below the muscle. And we know about some of the disadvantages of subpectoral breast reconstruction: impairment in limb function, animation deformity, increased pain, and some aesthetics related specifically to the animation deformity. And this is just, the classic paper back from the 80s showing that originally when we started using tissue expanders, these were actually placed on top of the muscle, but lots of increased rates of complications, maybe not great communication with breast surgeons, and there was a push to cover this with vascularized tissue, and eventually the moving around to ADMs and sort of dual plane and pre-pectoral. We know about the potential benefits of pre-pectoral breast reconstruction: reduced pain, decreased animation deformity, quicker recovery, better shape, and improved mobility in many of the patients with their shoulder complex. And so as plastic surgeons, really what this hour is about is sort of investigating an innovation in devices, and the innovation really is sort of in tissue expansion. So this is tissue expanders from Allergan and Mentor with a single port, fill port with suture tabs, which in Sientra also they have these devices that are available. But what we're gonna really have our panelists discuss tonight is this innovation in a device for breast reconstruction, for staged breast reconstruction, either tissue expander to implant or tissue expander to autologous tissue. So with our two other panelists, we're really going to sort of dive into this. And then, just to close my part with the introduction, this is Sientra's tissue expander, the AlloX, with its dual port. You have the aspiration port and the expansion port with the integrated drain within the implant. So I've been using this for about a year and a half. Dr. Mameni and Dr. Kanchwala have been using about 3 years each. So that's about 6 years total of experience together. And I think this is what we're going to sort of dive in with the panel. So I just want to introduce our first speaker, Dr. Ross Momeni, who's the Director of Clinical Outcomes Research in the Division of Plastic Surgery at Stanford University. He's also the Ryan Upson Scholar in Plastic Surgery, and he's Assistant Professor. So with that, Dr. Momeni, why don't you take it away?
Thank you very much, Dr. Sachs, for the very kind introduction. And thank you, Blaine and Sientra, for putting this together and sponsoring this event. It is a privilege, and indeed it is humbling to be invited. And I'm gonna share with you some of the thoughts that I have surrounding implant-based breast reconstruction, specifically staged expander implant-based breast reconstruction. These are my disclosures. I was a consultant for Allergan and Sientra. And with that, let's get into something that I'm particularly fond of, and that is history. And Dr. Sachs just now showed a historical paper on tissue expander, but really where we started with implant-based reconstruction was by Snyderman and Guthrie, who basically published this result in our leading journal, PRS, and this is what was done in the 70s. And when you look at the paper and when you read it carefully, you will realize that the authors were quite honest, and that they certainly did not exaggerate their accomplished outcomes in claiming that it did not produce any cosmetic triumphs. Fortunately, decades later, we can, following bilateral nipple-sparing mastectomies and implant-based reconstruction, accomplish outcomes that are not only functional, but also aesthetically quite pleasing. And we can do these things reliably. And the reason for these are technical advances in our technique, but also partnering with breast surgeons, as well as technological advancements, be it in expander technology or implant technology. And we'll highlight some of those points tonight. These advancements and certainly federal legislation and an increased awareness of reconstructive options has resulted in a rather favorable trend that is an increase in the number of total reconstructions being performed in the United States, an over 30% increase since the year 2000. As much as it pains a microsurgeon to say it, but it is really the implant-based side that has been the driving force for this. So it behooves us to be quite knowledgeable about all the different intricacies and advancements in the field of implant-based reconstruction, because that number has increased dramatically over the past few years. Now, when you think about implant-based reconstruction, you're really talking about a mixed bag of patients. There's substantial heterogeneity with respect to plane of device insertion, be it submuscular, subpec, pre-pec, and Dr. Sachs has commented on that, and we'll address that in a moment again. There is heterogeneity with respect to mesh products. Do you use allografts, xenografts, or even biosynthetic products? And as well as timing, stage reconstruction, DTI, and the like. This is the evolution that we just heard about, from sub-Q over full muscle coverage, dual plane with ADM, and pre-pec. And the astute observer will see that subcutaneous is essentially the same as pre-pectoral reconstruction. And the big question is, what has changed that we're promoting something that clearly failed in the hands of our predecessors 4 to 5 decades ago? And the reason for that is multifold. Number one, we have advancements and technical developments that are favorable in the field of surgical oncology. Our breast surgeons perform skin sparing and nipple sparing mastectomies. We have imaging technology that allows us to assess the quality of perfusion to the mastectomy skin flaps. We have mesh products and soft tissue support systems that allow us to improve reliability of our reconstructive outcomes. And also we have obviously advancements in implant technology and expander technology, and one of those devices we will talk in further detail tonight. I think that you can be a passionate surgeon with respect to subpectoral device insertion or pre-pec, but I think regardless where you fall on that argument, it is undeniable and beyond dispute that pre-pec reconstruction truly is the minimally invasive approach to breast reconstruction. And for the microsurgeons in the audience, effectively pre-pec is the equivalent to an SIEA flap on the abdomen. While we can debate whether a muscle-sparing tram is more or less morbid than a DIP, I don't think that any surgeon will argue that an SIEA flap is the least morbid of the abdominal flap options. And I think the same holds true on the recipient side when you compare pre-pec to any type of submuscular reconstruction. The criticism that has been voiced, however, for pre-pec approaches has been related to 3 areas in general. seroma formation, infection, as well as rippling. So let's tackle these and see how surgical technique and implant technology can help us address these areas. When you think of seroma, when you look at the literature, it is a published rate of anywhere between 2 to 12%. Admittedly, folks who do a lot of implant-based reconstruction will say that it is higher than this. And the problem with that is it prevents incorporation of ADM, that's one, but importantly, it is a risk factor for secondary infection. And an article, a very elegantly done article in 2019 demonstrated an odds ratio of over 15 where seroma is a predicating factor for infection post-operatively. And here, I think that we can leverage novel devices to potentially help us to treat these problems before they turn into infection. And whenever you talk about expanders or any type of device, it is interesting to me, at least, to take a look at the history where we were. And in the 40s and 50s, we basically used latex balloons with a multi-directional force that was exerted. And this was the first article that talked about expansion, if you will. Then we had the classic paper that Dr. Sachs quoted in the 80s on unidirectional expansion. We then had integrated port as an advancement, then suture tabs that was introduced, and now we have integrated drains. And the big advancement here is that you have effortless and easy access to the periprosthetic space. And as a result of that, you can aspirate seromas quite easily. Beyond that, it has applications that are currently considered off-label, but being that we're clinicians and plastic surgery is an innovative specialty, we can perhaps use this characteristic of the device to do things that the device actually wasn't designed for, and that is using it as an injection port, perhaps to inject antibiotic solutions or betadine, and we'll talk about that. So when disaster strikes and you have your resident call you and the patient is in the ER, has red breast, has elevated white count, maybe some temperature, what to do? If you look at the literature, unless the patient has a minor infection, surgery is always part of the treatment algorithm. And perhaps there's a way that we can avoid a trip to the operating room for our patients. How would we do that? So this is a very early pilot experience where patients who presented with cellulitis were washed out at the bedside. And so what was done here? Here, the drain port is accessed of the tissue expander and fluid is aspirated. Fluid is turbid, you can send it off for culture and gram stain, so that gives you a target. And then what we did was inject via the same port, initially diluted betadine and subsequently sterile saline, and we repeatedly washed it out at the bedside. And you get kind of this titration panel, if you will. So you aspirate, you irrigate and aspirate until the aspirate is clear. And in doing so, we were able to salvage 2 of 3 confirmed implant infections, or expander infections, I should say. Here we had 2 patients who both had gram-positive cocci on the gram stain, and on the culture it was coag-negative staph. And these 2 patients we were able to salvage. The patient that was not salvageable and ultimately required a trip to the operating room was found to have Proteus. And that is also in line with the literature, where we know that atypical bacteria, gram-negative bacteria, are less likely to be salvaged with just washout, and they need to go to the operating room. So if nothing else, the device gives you a lead time advantage, whereby at the point of contact in clinic, you can already collect a sample, send it to the lab, and it tells you already what the likelihood of non-operative salvage might be. As in gram-positive cocci, perhaps more likely. Gram-negatives, you should probably not put the patient on days of antibiotics, but rather pull the trigger on taking the patient to the operating room somewhat sooner. This is that same patient, 34-year-old female, underwent bilateral mastectomy, and reconstruction with expander, developed cellulitis, infection. This is her after completion of expansion without any surgery between these 2 phases, just bedside washout and IV antibiotics. And you will see that there is a delta between the tissue expander volume and the implant volume, as in the expander is always underfilled and you overfill the pocket with a larger implant in order to minimize the risk of, or the rate of implant rippling. And this is her after expander implant exchange. Again, 2 surgeries despite having an infection. This is another patient, 50-year-old, bilateral non-nipple sparing mastectomies, TE placement, right surgical site infection. You can see the area of erythema extending onto the chest wall. She had white count elevation. The initial fluid that was aspirated had, again, coag-negative staph. We did the same protocol, just washout at the bedside, IV antibiotics. The white count came down nicely. Interestingly, the fluid that we were able to aspirate on day 3 after washout did not grow anything. And this is her in clinic, again, without any surgery. Clearly, we still have to do expansion. This just happened a few weeks ago. It is always encouraging to see that experiences that you have as a surgeon in your practice is echoed by others as well independently. So this was an interesting article by Fairchild and colleagues looking at something entirely different, namely the difference between smooth surface and texture tissue expanders. And they discussed a case in this article where they used the drain port of the AlloX2 to inject vancomycin in a case of MRSA, and they were able to salvage this device and were able to then take the patient to expander implant exchange without any complications at 1 year post-op, which is quite remarkable. We proceeded and did a follow-up study of 99 breast reconstructions, so 58 patients. And basically what we found was that we were able to remove the drain at an earlier time point. Now, this has nothing to do with anything magical being related to the tissue expander itself. It doesn't dry up the pocket miraculously. What it does is it allows you to implement your usual drain removal protocols. As in my case, it is less than 20 cc's over 24 hours over 2 consecutive days. Whereas in the past, when reviewing the literature on pre-pec, there was almost a dogmatic adherence to 3 weeks drain persistence, irrespective of outcomes, of drainage volumes. And so this allows you to be somewhat more confident to rely on your already established drain removal criteria. And here again, the experience that we previously had was being echoed in the sense that we did have some patients, as in 3 of 5 infections that were salvaged non-operatively. And the one patient that developed a seroma, we were able to aspirate at the bedside, whereas the 2 patients who had a conventional tissue expander without the drain function required image-guided drainage for complete aspiration of the seroma. The process that we use in our clinic is as follows. So I fill the tissue expanders with air on the table, and then during the clinic visit, 7 to 10 days post-op, I aspirate the air out, and then I fill it with saline. And given that we have the luxury of an additional port with access to the periprosthetic space, I routinely aspirate any fluid that is in the pocket to really keep it dry. Now, this is an example of a patient who has obviously a substantial amount of fluid in there. It was about 30 to 40 cc's of seroma fluid. So we then proceeded and looked at what is the actual number of patients who do have a potentially clinically noticeable or relevant volume. And in 49 patients, 79 breast reconstructions, we had 9 patients who had greater than 30 cc's of volume in the periprosthetic space, despite having 2 drains in place. And so that is clinically meaningful, I believe. The final area that I want to cover real quick is implant rippling. And I think it is beyond any doubt that we do see implant rippling in pre-pectoral breast reconstruction. If you will, that's one of the Achilles heels of this reconstructive modality. And there are several things that we can do to minimize its occurrence. Number one is to keeping the pocket tight. And so when I measure the patient, I typically take a tissue expander that has a narrower base than the final implant will have. In addition to that, I underinflate the tissue expander, knowing that I will overfill the pocket with a larger implant. In the pre-pectoral reconstruction era, I believe implant choice is more important than ever before, because the implant ultimately is how your breast is going to look. You effectively just have skin, a little bit of ADM, and your implant. So the higher quality implant you have, the better your outcome is going to be predictably. And then the final thing is fat grafting. And I will tell you that while initially I was pretty much doing fat grafting on all patients, or 80 and 90%, now it's about 50% of patients that require fat grafting because of the implementation of these steps, keeping the pocket tight, using highly cohesive gel implants. And these are just two case examples. These are patients who underwent expander implant reconstruction, no fat grafting, 2 operations. 48-year-old patient, right breast cancer, bilateral mastectomy, right areola sparing, left nipple sparing. This is after expansion with 200 cc's of fluid. And this is her following implant exchange. And finally, I found a somewhat more challenging patient. This is a patient who had an augmentation years ago, presented with right breast cancer and desired bilateral nipple-sparing mastectomy. So she underwent said procedure with bilateral tissue expander placement. This is with the expanders in place, the 360. And in one procedure, I was able to aug that, if you will, by over 200 cc's to 565. The one point that I wish to make here is you see that the patient also underwent radiation. This is the patient almost 10 months following radiation. And I think this is one of the benefits of pre-pec, where you don't see secondary distortion of the implant subsequent to radiation, something that I used to see more frequently with subpectoral device insertion. So when you put all this together, I think that we now have a tissue expander in place with an insurance policy, in the sense that you have a drain port that allows you to access the periprosthetic space whenever you feel a problem has arisen, whether it is a seroma, whether you want to use it for diagnostic purposes, to aspirate fluid, to rule out infection versus, let's say, red breast. It permits for, allows for an expeditious intervention that can truly guide clinical treatment. If you aspirate gram-positive cocci or gram-negative, that will potentially alter what you do surgically. And thus, it increases the safety margin in expander-based reconstruction. And innovations in gel technology have truly translated in superior clinical outcomes. In the past, we did have entire book chapters devoted to silicone bleed and the like, and we don't see those things anymore. And in my practice, at least, it has resulted in a reduction in the rate of secondary fat grafting. And with that, thank you very much. Justin, you're on mute. Yeah.
You're good now. I just unmuted you.
Thank you. Thanks for saving me, Blaine. So, Dr. Momeni, I have just on the data where you showed comparing your aspiration of the smooth versus the textured tissue expanders. What do you think's going on there? Because it looked like there was a trend towards a higher drainage for the smooth. And also, just another question: how many times since since you've started using AlloX have you sent patients to interventional radiology for drainage procedures? So those two questions. What do you think's happening between smooth and textured? And 2, how many times have you utilized the services of our radiology colleagues in the last 3 years?
All right. So thanks for the questions. Number one, I think, so the smooth versus texturing work is actually part of a larger project, if you will. What is happening there, I actually don't know why we would have more fluid on the smooth versus the texturing. I think that the N in the textured cohort was too low to be able to draw any meaningful conclusion. What I can disclose, however, is that when we sent the fluids for culture, we did have a significant difference in culture positivity in the texturing. So the fluid that I aspirated from the textured port was more commonly positive without any clinical signs of infection.
I think, this is, this is empirical, a priori assumptions, but I really think there's something in the texturing versus the smooth of infections and seromas. And there's a lot of stuff that we can investigate with this. How do bacteria, sort of get into those nooks and crannies, the increased surface areas, there's something happening there, and also just the amount of seroma.
I think you bring up a very valid point in the sense that we have a window into the periprosthetic space now that is easily accessible. And so at various time points, you can access the pocket and you can sample fluid and you can investigate answer any sort of question.
Right.
Your second question was the IR piece. I haven't sent any patient to IRs for aspiration of seroma since having this device. And if nothing else, it is a logistical relief for us in clinic, where nobody has to make phone calls, put in referrals, call the colleagues, ask for favors. And for patients, it's also easier and more satisfying to have any potential problem being treated and addressed at the point of contact.
Yeah, I mean, I was hoping for that response. That's wonderful for the patients and wonderful for your practice. Okay, with that, I'm going to introduce Dr. Sahel Kantwala, who's the chief of plastic surgery at Pennsylvania Hospital. He's an associate professor of surgery in the Division of Plastic and Reconstructive Surgery at Penn Medicine. And fun fact, he was my fellow, and he was a fantastic fellow at the MD Anderson Cancer Center when I was junior faculty. So I'm really excited to hear his talk and to hear about his innovations with AlloX and also autologous tissue. So with that, Suhail, take it away.
Thanks, Justin, and thanks to Blaine and Sientra for putting this together. So, fun fact, Arash was one of my fellows a while ago. So it's a continuum. It's a continuum. All right, let me just make sure that I'm sharing this appropriately. Are you guys seeing my screen?
Yes.
Okay,
yeah.
Fantastic.
Perfect.
So, it's interesting. Arash actually started using the AlloX2 a little bit before me, and we had talked a lot about it. And I was initially a reluctant adopter of it, but I want to explain to you a little bit about how it fits in into my sort of worldview, thinking about breast reconstruction. So, just in disclosure, I work in Philadelphia, and what that effectively means is most of my patients are obese smokers who need radiation or have had radiation, which means that breast reconstruction in general is a little bit more on the challenging side. And to be honest, I was not a fan of pre-pectoral breast reconstruction for a variety of reasons, mainly because of the complication profile of pre-pectoral in my environment. In addition, it always takes me a little bit of coaxing to start new things. And so this was a case that really changed my thinking about things. So this is a patient who came to me for autologous bilateral free flap breast reconstruction. It's kind of what I do. So I signed her up without really regarding some of the reasons why she has this big scar or her medical history to the extent that I should have. But she got a decent result post-operatively. But the part of this that I'm skipping is that I ended up losing that left flap. And this was both devastating to her as well as to me. And she refused to let me do anything unless it was an outpatient procedure. And so this is actually my first pre-pectoral tissue expander reconstruction. So in one outpatient procedure, I placed a tissue expander in a delayed fashion and then expanded her up and then switched her out. And essentially, if you can get in 2 outpatient procedures a result that's pretty close to what I was getting with autologous reconstruction, it really made me think about what I was doing both with autologous reconstruction and with implant-based reconstruction. The problem, though, as well as that first case went, and I wanted to sort of just jump into pre-pectoral reconstruction, there's some significant barriers to the adoption of this technique. For many of you who know me, I enjoy skiing and sea kayaking, and on my side, I manage a burn unit. And so this is the problem with some of the things that we're faced with. I'm often seeing things that make implant reconstruction just very, very challenging. And I know that many of you can probably relate to this experience. But in addition to ischemic flaps, we fundamentally have an issue with pre-pectoral reconstruction. As wonderful as it is, it requires the use of a large piece of ADM, which in and of itself is seromogenic. Forgetting the cost of ADM, there's a high seroma rate with this technique. I know that the literature says somewhere between 10 to 12%, and I agree that that's what the literature says. In my practice, it's far higher than that. And the problem with seroma formation not only is the seroma, but the fact that it leads to non-incorporation of ADM, as Arash mentioned, and then the subsequent secondary infection. And you bundle all that together into a busy practice. And effectively what it means is you do a great operation, and then 1 to 3 weeks later, a patient shows back up in your office or in the emergency room with red breast. I'm at a different hospital, and that really cramps my style. My practice, my lifestyle can't take that, won't take that. And that limits my ability to do a procedure that I think has some significant value for my patients. And this is how I started to use and get better experience with prepectoral breast reconstruction, because I was, quite frankly, scared of those complications. So I started using it in my delayed immediate breast reconstructions, where I was using the expander as a babysitter. And I started off with the Allergan full head expanders. I also used the Mentor Artura expanders. I have great relationships with both of those companies, and they're great expanders. But they're kind of similar. I mean, as all expanders up until recently have been. The thing about the AlloX2 is that it's a fundamentally different device that is uniquely suited to prepectoral reconstruction, because it allows you access to that pocket to actually not only manage complications if they arise, as Arash mentioned, sort of like an insurance policy, but I feel actually prevent some of those complications from the get-go. There's some technique, indications and things that are important to talk about. One of the biggest things I think, to start using this expander is, the great thing about it is it's got 2 ports. One of the downsides of it is it's got 2 ports. It's a bigger, footprint, and you got to sort of take that into account in your incision placement and how you manage this. But it's also important if you, especially depending on how you do prepectoral reconstruction. My favorite technique is to wrap this with ADM. It's important not only that you flush that port as you start to use it, so you don't get any negative pressure and you can easily drain when you need to, but also that you need to make sure that there's plenty of gaps, either by fenestrating the ADM, as some do, or in my case, I make big holes so that we can actually drain the part of the pocket that's important, which is the space between the ADM and your mastectomy skin flap. Now, in terms of the insertion and how you handle this, this early case sort of is a good example of how I manage patients that are having a nipple sparing and inframemory fold. So this is one of the early cases that I did with prepectoral reconstruction. It was actually a colleague of mine's wife, and she had a history of opioid dependence and specifically sought out prepectoral reconstruction because of the decreased pain that it offers. She knew a lot about this, and in fact pushed me into doing this before I was super comfortable with the technique. In this setting, I think it's critical that you do things to manage your complications from the beginning. And it's sort of like when you're putting in a plate on a maxillary fracture, you want to make sure that there's a cuff that you can close afterwards. I ensure that there's a cuff of good tissue that I'm going to be able to close afterwards. So I actually start the mastectomy. I've got a great relationship with my breast surgery colleagues, and they let me start the mastectomy. I enter that, make a full thickness incision all the way down to chest wall, and then allow them to basically re-enter the mastectomy plane. But this gives me a nice cuff of tissue so that when I'm done, I can close this up and really have this a good closure. So this is the patient after the initial expansion. She wanted a contralateral augmentation, wanted to be bigger, and this is her result. And I was super thrilled and happy with this result. And that's the beauty of prepectoral reconstruction, is you can really get very nice natural results. Another patient, this is again a high, important case for me. It's a nurse practitioner, my wife, and I know 2 things about her. 1, she's a type 1 diabetic, and 2, she needs postoperative radiotherapy, doesn't want autologous reconstruction. I was a little bit concerned about this case. This is her after the initial expansion. You can see her insulin pump, and this is what she looked like after radiation, and this scared the heck out of me, because I had no idea what was going to happen. And quite honestly, this kind of a result in subpectoral reconstruction is going to be a disastrous outcome. I'm never going to be able to get a good implant reconstruction. And what surprised me about this, and has repeatedly surprised me, is that with prepectoral reconstruction, radiation is tolerated much, much better. This is 6 months later after I switched her out for an Allergan implant. And really her only concern here is the rippling, the obvious rippling. And I took that. I said, listen, this is a win in my book. I was about to fat graft her, and that's when I really started to think about what this really is. Yes, it's a little bit of a soft tissue deformity and deficiency, but it's also a structural problem with the implant that I chose. And so what I decided to do is switch her to a higher cohesivity implant that has a better gel shell integration. This is the HSC Plus implant. And so when you see her switched out now, all I've done, there's no fat grafting here. I've just taken the old implant out and exchanged it for a more cohesive implant. And you can see a pretty dramatic change in the rippling. And so I've gone to, just as Arash has, gone to using more higher cohesive implants, because I think with prepectoral reconstruction, it really matters. The next thing I wanted to talk about is really how I use that drain port, because I think it's important for the management of problems, but I think it can critically prevent the problems from the get-go. And so prepectoral reconstruction, The surgery itself can be really straightforward, particularly if you wrap, but it's everything you do after. That's the nuance of the surgery. Managing the skin, managing the dressings. This is just one method. And in my view, what I like to do is what I call active seroma management. So my drain protocol is that all drains are left in for at least a week, regardless of output. After that, they're removed when they're less than 20 cc's a day. And importantly, after all the drains are removed, the patient comes back to the office 2 days later, and we access that seroma port or the aspiration port. The amount of seroma that we see, that we aspirate, determines the next post-op visit. What do I mean by that? If a patient has greater than 10 cc's of aspirate, then they come back 2 days later for another aspiration. What I want is that pocket to be dry, dry, dry. And if you think about it, if what we're trying to do is have ADM incorporate onto the mastectomy skin flap, and you sort of liken this or to analogous to what a skin graft would be on a recipient bed, if you saw initially after taking off a bolster on a skin graft, a little hematoma, a little seroma underneath that skin graft, you wouldn't just leave that alone, because you know what's going to happen. That part of the skin graft isn't going to take. What the AlloX2 allows you to do is effectively drain that seroma so the pocket's dry, and it's for increasing the chance that you're going to have a better ADM incorporation. And that's effectively what I've seen. So the last 50 consecutive patients, we've been doing this now. We have about a 6-month follow-up. We're going to publish this data, but basically we've had no post-operative seromas. I've had a 90% ADM take. We've been able to decrease the total duration of drains, which is a really critical feature. Now that you manage a lot of the pain and the discomfort of the reconstruction, the drain is the worst part of the reconstruction. In this series, I had one infection, and I'm going to show you how I managed that. Importantly, if you're going to be routinely using the drain, I think it's important to know that after a period of weeks, if you haven't aspirated for 3 or 4 weeks, a lot of times you'll have a little bit of ingrowth into these little drain channels. And so if you don't get much aspirate back, it doesn't necessarily mean that there's no seroma present. Sometimes you have to actually instill some fluid and actually flush that port in order to make sure that it easily aspirates. So don't just rely on the fact that you didn't get anything up in the initial aspirate. I too, like Arash, have had some post-operative infections, and this has been a godsend in my practice because this is, I'll show you this example. This is an inframammary fold incision that we use for a nipple-sparing mastectomy. She's had a prior abdominoplasty. This is her dressings as she's coming off. She's having a relatively uneventful post-operative course, and 3 weeks post-op. Again, this is the typical time frame. It comes out of the blue. You don't expect it. She was doing great, but she has a little bit of necrosis on the underside of that nipple, and that caused an infection. She shows up to my office with a red breast at an inopportune time for me to take her back to the operating room. Arash had already, shown me his experience, and so I did pretty much a similar thing with a dilute betadine irrigation system that we rigged up, and we were able to get her out. 3 weeks is not enough time. If I'm going to take her back, I'm going to lose that ADM. It's not going to have been incorporated. I push her out an additional 3 weeks, and now I'm able to, at 6 weeks, do an earlier implant exchange than I typically would do, but it has allowed that ADM to incorporate, and importantly, it saved her an unplanned return to the operating room and kept me out of the operating room on a Friday night. All of those things are important. I'm not putting the order of importance that you can decide. This is another example, patient doing great with her initial expander placement, and then just shows up randomly with red breast. Same idea. We saved her a return to the operating room, got her out, and we're able to essentially get a nice result at the end of it. So I'll just conclude with saying that in my view, if you're going to do a lot of pre-pectoral breast reconstruction, which I think there are many advantages, this expander, the AlloX2, really allows us to manage complications and prevent them from the get-go and get what we all want, which is achieve better control in our reconstructions. Thanks very much.
Dr. Pinchwala, that was outstanding. Just a couple questions specific to your presentation, and then we're going to open it up to the group. You mentioned about radiation being tolerated better in the pre-pectoral space. What do you think? Some of the what are the factors behind that statement? Because I agree also, and I can probably answer after you answer too.
Yeah, I mean, Justin, I think this is something I was surprised by. because I, went through the MD Anderson experience of delayed immediate breast reconstruction where everybody was getting fried. And then you have to basically debride most of the skin afterwards. And you have this, rock hard expander that's at the clavicle. That was my standard experience with radiation and implant breast reconstruction. I think what's happening, and what I didn't appreciate before, is that a large part of what happens there is fibrosis in the muscle itself from radiation. I think that the injury to radiation affects muscle a little bit harder than skin. Even what we're seeing on the outside is a lot of the erythema in the skin that largely will recover. So pre-pectoral reconstruction, you're still getting that fibrosis in the muscle, but it's just not affecting your device in the same way that it otherwise.
I just want to share with everybody because I think it's an important thing. So, observationally, just within my patient population. So if a muscle is contracting over a foreign body, it's gonna treat it as a foreign body. It almost treats it like a joint. And often I've actually sampled that capsule and it comes back as synovial cell metaplasia. And if you get radiated, that capsule is so dense, it's under the muscle, it's thick, it's on the chest wall. So I think that's what we were seeing for so long. When you radiate skin and fat, maybe on top of ADM, on top of an implant, you don't have that muscle contracting on top of it. I actually think there's less of a fibrotic response, but I agree, your muscle becomes fibrotic. And I think, remember the times when we would have to harvest the mammary vessels after a tissue expander that maybe had been infected. And I mean, you're talking about a total transformation in the way that we treat autologous tissue by having that really supple skin envelope with and without radiation. So the innovation definitely is, I think with AlloX, you're being able to control that pocket, the seroma, the infection, but also, combine that with pre-pectoral. And, it's like two innovations right on top of each other that are really force multipliers for really wonderful ways to either do autologous, which you've shown, or implant-based reconstruction. So with that, Blaine, have we been getting some questions?
Yeah, so we had one question so far from Dr. Afifi. Dr. Afifi, if you want to come off a mute and turn on the camera and ask. Otherwise, I can do it. There he is.
Hi, everyone. Again, there's a great lecture. Thank you very much. I've just started using this expander, and I love this expander. My question to you all is, do you ever do it without any drains? Because I think that's been a big change. I've tried it and I love it. The problem is that the nurses are getting upset at me because they do spend a lot of time emptying the seromas regularly. And thank you again for a great panel.
I'll take that if that's okay, Justin.
Yeah, please run with it.
So first of all, I agree. Drains are, now that we've taken care of a lot of the discomfort from breast reconstruction with the pre-pectoral, advance, the drains have become the biggest source of complaints for patients. And so certainly the AlloX2 with implant-based reconstruction, if you're using ADM, I think, at least in my practice, it's allowed me to decrease the duration of drains. But with implant-based breast reconstruction, if you're using ADM and you don't put a drain in at all, you will get an obligate seroma and then your ADM is floating around. So I know of surgeons who don't use ADM with pre-pectoral reconstruction and they've been able to do it without drains. But I think if you're using ADM, it would be challenging to get that ADM to take. On the other hand, I have had a great experience with doing a drainless autologous technique where you initially stage essentially a babysitter technique where you use the AlloX2 as the only drain for your mastectomy. And once that pocket's dry, when you go back to do the free flap now, you can do the free flap by essentially putting quilting sutures in the free flap. So this lets you do so many interesting things, whether it's implant breast reconstruction, autologous breast reconstruction, it gives you flexibility you didn't have before.
Well, I think along those lines, and we'll let Dr. Momeni speak about this, but this is the obvious next step for the expander is to install some other drain ports, maybe medial, lateral, superior within that, so you can actually access areas on the chest wall that maybe you can't reach when it comes down inferiorly. Dr. Momeni, any tips and tricks for draining those seromas with the tissue expander in place, with the AlloX in place in the clinic?
Yeah, so what I've noticed is that initially, and that was also what I showed in the video, is I used the 21 gauge butterfly that comes with it. And the problem is that if you have the seroma sitting there for a little bit, it becomes somewhat viscous, and then you have problems aspirating because of the caliber, the gauge of the needle. And so what I have been doing is I actually use an 18 gauge needle to access that drain port. And with that, it has been easy to do. Now I can already sense my dear friend Suhail opening his eyes, because an 18 gauge is pretty huge. And anybody who has watched Pulp Fiction, it's a surreal experience the first time to do it, because it's literally like John Travolta and Uma Thurman. But it works very, very well. And you really can pull out the seroma fluid with ease. The one thing that I will say is the gel on the port is quite thick. So you want to make sure that you have ever so slightly an angle when you go in with the needle, and keep the bevel down towards the expander itself to really be in the chamber to aspirate the fluid. Otherwise, you're within the gel proper, and you say, oh, the device doesn't work, the drain is malfunctioning, and you get upset. So those are the things that I have been doing. So I basically, short answer is large gauge needle, 18 gauge, and I use that pretty much with impunity.
What about for both of you, when you're using ADM, what's the best way to fenestrate that ADM inferiorly so that you don't get it caught when you aspirate in clinic, or don't run into trouble with it?
For me, I put in large holes at the inframammary fold, and that's worked out fairly well for me. I actually don't like fenestrating the ADM, but you know, that's just my approach.
I mean, but you fenestrate it just at the base where the ports are. Any tips and tricks if it gets, you know, if you draw back and you don't have anything, but you still feel fluid down below?
I think you should flush, you know, you should at least try and flush with 5 to 10 cc's. We do that routinely, actually. And, you know, there are lots of reasons why someone might be concerned that flushing in some fluid could cause a problem. But honestly, I've been doing this routinely now for years without an issue.
Arash?
No, I would agree. So I along the IMF, I merely make a slit. I don't actually cut out a hole, because by making a slit and then when I stretch the ADM, it basically becomes somewhat of an oval already. I think those are minor points, and I don't think that they really translate into any difference in how the breast ultimately looks. That's just technical preference and what has worked for me. For full disclosure, I mean, I also have been in a situation where I aspirate on the drain port and it doesn't come back. I don't get any fluid back. And then I have flushed it, and then basically I, if you will, massage the whole pocket to see if there is any fibrous connection where things are maybe loculated, to really force it down to the IMF, to then have a fluid-filled pocket there and then aspirate it out. It's not common, but it does happen. And one word on that is, when we use Blake drains or JP drains, those drains also at times clog and don't function the way we want to. So I think that the expectation that this drain will always work is maybe an expectation that is too high. But I think in the vast majority of cases, at least in my experience, it has worked beautifully. And it has saved me and saved patients the trip to the operating room unnecessarily at times.
Okay.
So Justin, I want to chime in for a quick sec. We recently got an ultrasound in our office. Breast surgeons have always had one, and we have not. And I've been playing around with that ultrasound, and it's interesting because you can detect small seromas that you otherwise wouldn't have been able to detect. And I actually am in a work environment where I don't have the access to AlloX2 in every hospital I work at. So I kind of have a kind of controlled experiment going where I have to use more old school techniques to drain seromas in the non-AlloX2 cohort. And then and it's interesting because you don't realize it's very hard to detect without ultrasound a 10 or 15 cc seroma. It will look, the pocket will look dry. You'll see skin and the expander port, and you'll be like, oh, the patient's doing great. And I don't know what the clinical significance of a 20 cc seroma is. Is that going to lead to an infection? Is it going to lead to ADM non-incorporation? I don't know that. I can't prove that, but I do know that it makes me feel more comfortable to not only have drained that pocket dry, but to be able to verify it with ultrasound that it actually is dry. Because I can't imagine that seroma there is helpful in any way.
I mean, it's first principles thinking. If you have serous fluid on a device, on ADM, in a warm, moist space, there's a potential for infection. So if you can drain that seroma, I think that's probably the logical thing to do, especially also for incorporation, because the skin and soft tissue lifts off, and leading to more dead space. So more dead space, the body is made out of 2/3 water. If you have dead space, it's going to fill with fluid over time. So just off on some tangents, what are the two of yours? What's your technique on fat grafting? When do you exchange the tissue expander to implant? When do you do fat grafting? Do you do it at the same time? Do you wait, come back? What's your, how many average fat grafting sessions do you typically do in a patient that goes for tissue expander to implant? So for both of you.
So I don't fat graft ever at the time of the expander implant exchange. And the reason why is just when I go back to do the expander removal and implant placement, I almost always have to do a superior capsulotomy. And so at that point, it is very difficult for me to envision the plane in which any fat graft could be placed. So my worry would then be that I have kind of graft floating around the device. So what I do is I do the capsulotomy, do the implant exchange. I'm oversizing the patient in hopes that implant rippling will not be a problem, and then let everything settle and see if and when and how severe the rippling is. And then I go back electively as a secondary step to do fat grafting. So I never do it at the same time.
I've agreed with every single word you've said up until this part of the talk, where I make the tissue expander very tall, and I put the ADM and I tack it right below near the clavicle. So when I take it out, I actually have that space ready in my mind to fat graft. So I agree with everything you've said for the last 55 minutes, but at tissue expander to implant exchange, I'm doing some great fat grafting in the superior pole pre-pectoral space above the ADM. Push the implant down. Dr. Conchuala?
So what's interesting? There's a gentleman by the name of David Otterburn. He's in New York.
Yes, we know that young man.
So he's described to me a bunch of times the experience of not using ADM in pre-pectoral breast reconstruction, and his thought process is that what you actually want is a little bit of capsular contracture, not a lot, but just a little bit of capsular contraction. Because I frequently thought the problem is we've designed the surgery well. We have ADM there. Well, what you're doing with the ADM is you're preventing that skin envelope from retracting around that expander because you've stopped the wound healing process by ADM incorporation. Well, if we could get a little bit of capsular contracture, I think you'd see a little bit less rippling. And part of the rippling we're getting is a little bit by design of the operation. Now, for me personally, I don't know that I can control capsular contracture, and I think I feel more comfortable with ADM as a more established technique, and that's why I use it. But I do fat graft routinely. I tell patients if it's not 2-stage breast reconstruction, it's 3-stage breast reconstruction. I don't do a lot of fat grafting at the time of implant exchange for similar reasons to Arash, but I think it's a valuable technique, and it softens the result on almost every patient.
I think along the lines of capsular contracture, I mean, I would love to see a show of hands from every single person who's watching this is who gets capsular contracture in pre-pectoral breast reconstruction, because I surely don't. I do not see capsular contracture ever in any pre-pectoral breast reconstruction I do, unless there's radiation. What do you think of that statement?
Well, you're using ADM though, right?
Right, but you would see capsular contracture in the setting of subpectoral breast reconstruction with a tissue expander or an implant.
The question though is whether that is capsular contracture or whether it's the muscle contracting down secondary to fibrosis, right? So when you have ADM in place, that might be a protective measure against capsular contracture. But if you're in the dual plane, inferiorly you have ADM, but you have a contracted, radiated, constricting muscle on top, then it's not the capsule that is actually displacing or changing the shape of the device, but it's actually the radiated muscle, which is kind of the experience that I'm sure we've all had when we go in and then,
I mean, if you look at it, it's the capsule is fibrosis, so it's collagen. So that's what's around the tissue expander or implant below the muscle. Because when you go back there, yes, the muscle has been radiated, but it's actually it's the collagen or it's the fibrotic capsule. You know, when you do an en-bloc capsulectomy, that's what you're taking out. You're taking out the capsule around the implant, even below the muscle.
Right. No, that is true. That is true.
Yeah, on that note, we did have a question come in privately to me, just asking to comment. You've talked obviously a lot about pre-pec breast reconstruction, but any comment on the utility of the AlloX2 in subpectoral breast reconstruction? Any differences on how we'd use it or what's to be expected in terms of benefit?
Well, I can address that briefly if that's okay. So I think that you do have seromas also with subpectoral reconstruction, and the same principles apply whereby if you have seroma that is undrained, that can translate into an infection. So whether the device is above or below the muscle, having access to the pocket that allows you to drain any undrained fluid collection certainly is beneficial. So I definitely stand by my statement that it is an insurance policy, regardless where the device is placed.
Yeah, I don't really have any experience using it in the subpectoral, partly because a few years ago when I started pre-pectoral, I pretty much made a hard shift. So I've essentially stopped doing subpectoral reconstruction.
Yeah, and I have the same comment. I only perform pre-pectoral breast reconstruction. In 2015, I bought an electric car and started doing pre-pectoral breast reconstruction, literally at the same time. You know, it was like just thinking about, I was thinking about different things. The reason why I transformed into pre-pectoral breast reconstruction was I was, doing this. So 2015, I was about six years faculty, and I was upset that I was hurting patients. Expansion was so painful for patients in clinic. Even, post-operatively, these female patients were in so much pain. And, so we just transformed. And then, one of the first papers I wrote on pre-pectoral breast reconstruction is we counted up the narcotic units for pre-pectoral versus dual plane subpectoral. And it was literally night and day. Patients just don't take narcotics with pre-pectoral breast reconstruction. The two of you have any similar experience?
I'll echo that completely. When I first started in practice, my clinic day was Friday. And I very quickly moved my clinic day from Friday to Thursday, because what would happen is you would expand a patient on Friday and they'd show up in the ER on Saturday with pain, and the ER can't do anything for them because they can't take any fluid out. And it's an absurd statement that what I was doing in clinic was that painful 24 hours later that I had to move my clinic, but that's what life was like before. Now, maybe I shouldn't have expanded as much as we were. We're probably being a little on the aggressive side, but the bottom line is it's more pain than if there's an alternative strategy that doesn't require that kind of pain, then I think it behooves us to really try and perfect that strategy, warts and all, whether you have a slightly higher, we look at complication rates very differently. There's a kind of complication that causes me to go back to the operating room and get out of bed in the middle of the night. And then there's the complication as the patient experiences them, right? So seromas are things that we don't want because they cause infections and cause, but the reality of it is patients don't want pain. And you wouldn't want to go through it, I think, if you had the other option. Anyway, my 2 cents.
If I could just give 2 cents on some feedback we've got over time since we launched this device. I think the real difference in subpec, as you've just talked about with pain, is that people aren't, you're usually not filling the device up as much on the table. And I think the thing that comes into play, you showed those great pictures of the expander being folded so that drain is flat and showing up. That becomes really important when you're doing subpec, and especially if you're filling anything less than 100 cc's in the OR, that drain, if it flips up, can put a little pressure on that skin flap. And then also if you've sucked it all the way down so it's completely empty and almost negative pressure inside, that drain port is actually kinked off until you have at least 50 cc's of fluid inside the expander. So that's just important. If you're doing subpec, you know, it's really not going to fully function until you have at least 100 cc's filled into the expander there. We also pleased to have a patient advocate on the call today. So Terry, if you'd like to ask your question of the panel as well.
Yeah, it was a very generic question, Blaine. And I have to tell you guys, this has been such an excellent presentation. I was in another one about a week ago with some other micros. First of all, I want to tell you, it is amazing for me to be here, truly, because I'm kind of a surgical junkie, unlike some of your patients who probably don't want to see anything. But what this allows me to do is understand the intricacies of what you guys have to do to make this better for us. But in relationship to this webinar, this is such a learning process for me. I never had expanders. I had delayed deep. So my breast surgeon, who Dr. Sachs, I think she went to UWash years ago. She did skin sparing, nipple sparing, to give you guys a background. And then I had delayed deep 7 months later after my double mastectomy. So I never had expanders. And yet so many women talk to me about their expanders. They can't wait to get them out, or, you know, the uncomfortable feeling that you all speak about naturally. It's, you know, we go through uncomfortable feelings when we're healing from deep too. So it just is what it is. If we would all choose not to have any of this, we would, but it is what it is. So here's my question. You know, when a patient goes in and they talk about any type of reconstruction they're going to have, I mean, do they ever think to ask questions about expanders, or do you just tell them, you know, I'm going to use an expander on you, and that's going to be part of it? Do you know what I'm saying? Because there's different type of expanders. And you guys presented so many studies, so many issues, so many techniques tonight about expanders. I don't know if are patients going in and asking any of you about anything specific about expanders? Does that make sense what I'm?
Absolutely. I'll start if that's okay.
Yeah, go for it.
So, you know, it's a very nuanced question in some ways, because in order for a patient to really know about the various types of expanders, they really would have to have done a fair bit, you know, higher level reading to get to that level of detail. But the reality is, in my practice, I don't typically give patients an option about what kind of expander to choose, because number one, it's a temporary device. I'm not intending that to be a final device for that patient. And number two, I think there are significant differences between expanders now. In the past, I wouldn't have probably cared as much, but there's some pretty significant differences. And something like this, the AlloX2, where if I'm choosing to do pre-pectoral reconstruction, it makes a big difference to me how to manage that patient. I wouldn't really give a patient that option. Obviously, the type of implant, they're heavily involved in that, but not so much with the expander.
Terry, I'm going to just jump in, you know, with shared decision making and really allowing the patient to make the most informed decision. You know, I offer 4 different ways to do breast reconstruction: nothing, your own tissue, implants, or a combination of your own tissue implants. That's my shared decision process. I say we can do implants, your own tissue, combination. This is the information. But I think to Dr. Cotruella's point, if you're coming to us for breast reconstruction and it's going to be tissue expander, the innovation is what we're going to use, because that, you know, we want to make sure that we drain the seroma to prevent the infection. But I think the tissue expander is something that's a little bit beyond the shared decision model. That's sort of where you put your trust in the surgeon to use the best device or equipment. Maybe, I hope that answers your question a little bit more nuanced.
It does. Those are some really good points that you bring up. But I guess from a patient standpoint, you know, I would throw that into the mix in your conversation just to boost their confidence and say, hey, we're using this. This is what we're using, right? But let me tell you how great it works. And let me tell you the success rate I've had with it. And let me tell you something, you know, that could happen, but I always say the model of a good breast reconstruction journey of any kind, whether you have complications or not, is that your surgeon carries you through even with those complications. So, I mean, if you give them all the information up front, and I mean, by all, I just mean, this is a tissue expander I use. This is why I trust it so much. And this is why I'm going to put it in your body and what it's going to do for you. So that's my free 2 cents for the night. But I'm learning so much. I didn't have expanders. I love learning this stuff. So thank you all. And I am going to have to beg off very soon because the husbandator his stomach is growling. And
Terry,
it's dinner time.
thank you so much for being a warrior and a champion of knowledge. You know, on social media, you're fantastic. You're always, you know, promoting ideas and really helping share knowledge. So, you know, I mean, you're a patient and a educator and everything more than that. So thanks so much.
Well, you're very welcome. And I am going to leave the meeting. But again, I always feel like this is a team effort. I learned so much from all of you. So thank you for allowing me to peek in tonight. And Blaine, I'll be in touch.
Dr. Momeni, any comments?
No, I think that you and Sohail and Terry, you covered all the issues related to device selection. I typically offer patients, every new patient basically attends a 1-hour class with me on the days where I have clinic, where I go over all these options, independent whether they're going to get free flaps or implant-based breast reconstruction, and then I see them shortly thereafter. But the foundation is set across the board for every new patient that enters the practice of all options, including the one that you mentioned that is no reconstruction. So that's what I go over in my new detail. And that's basically the extent of the shared decision. So I present it to everybody, and then I do it on the individual basis shortly following the 1-hour class.
I have a question for both of you before we get off. ALCL, every consult discussion, when do you bring it up?
I can answer that real quick first. I bring it up. So I have in the class expanders and implants that I pass around so that everybody gets a feel for it. I have smooth and textured devices. And at that point, I discuss the issue of ALCL. And I personally just use smooth devices, but I still have them get a feel for the textured devices for completeness sake, because I don't want them to leave and pick up some information somewhere else that they didn't at least hear about during the consultation.
Justin,
Blaine, can I make a comment?
Yeah, go for it.
Yeah, I'm Jeffrey Durham-Smith in Louisville. I've been doing breast reconstruction for 40 years. I trained in Melbourne with Ian Taylor. Very early on in the discussion, Sohail was talking about drain tubes being the patient's worst problem. And I just think that shows how far we've come. When the drain tube is their worst issue.
Well, but yeah, I agree. It's remarkable because even a few years ago, that was not the case, right? The surgery itself was the big problem. But I think that as we keep advancing in what we're doing, you have to attack that next thing, you know, and thankfully this is that one of the next, you know, things to attack.
Agreed. Great. Thank you.
Blaine, any park questions out there in the interweb?
No, we can open up for a few seconds. Anyone still on the call? If you have any questions, feel free to speak up now.
Yeah, we've gone over a little bit in time, 8:43, but
yeah, we appreciate all your time here, and it doesn't look like we have any more. So thank you guys very much for the presentation. Great job with all the information on your different perspectives. Thank you to the Plastic Surgery Research Council for joining with us and partnering with us on this educational event. I put in the comments there in the chat, ways that you can get in touch with Sientra. You can also email me directly if you have any other questions for the panel, and I can forward it on and put you in touch. So thank you all.
And thanks, Blaine. I just want to close out. I really want to thank Dr. Romani and Dr. Conchuala. Incredible presentations, a lot of experience with a new innovative device, a lot of experience with autologous and implant-based reconstruction. And for the Research Council, lots of opportunities to study some good clinical outcomes research, both on the microbiology side, tissue capsules, and then shared decision making. So I think the future is bright for what we're doing in helping patients. So Arash and Suhail, want to make any final comments before we head off? Suhail?
I was going to say, Justin, thank you, and Blaine, particularly, this was a lot of fun. And every time we do something like this, I learn something. So I really appreciate it.
Arash, final comments?
Agreed. No, I agree with everything that was said. Thank you very much. Sincere thanks.
All right, guys, stay tuned for some more innovations in breast recon from Sientra, and that concludes. Talk to you later.
Bye-bye.
Thanks. Bye.